this closing plenary is to some extent a culmination, but also an opportunity for us to focus a little bit more on some topics that have come up throughout the day. And we want to focus primarily around sort of behavioral health issues and around workforce issues. Those things are tied together, which we're going to talk a little bit about. And I've just been really pleased to be joined by two speakers here. We have Eric Hunter, President and CEO of CARE Oregon, and Felisa Hagins, Executive Director at SEIU for Oregon. So I'm going to just kind of turn it over to you, Eric, to kick us off to really talk about particularly the behavioral health issues and where we are with that, and then we'll move to Felisa. So go ahead.
All right. Thank you so much. It's great to be here. I wasn't able to make the whole day, unfortunately, but the sessions I did see were insightful, and I think this is one of the conferences that I really appreciate every year because it gets all of us together to talk about real solutions, what people are going through, how to sort of move the needle on some things. And so hopefully we can continue that dialogue a little bit and get some progress going. But as Kathleen mentioned, I'm Eric Hunter, CEO of CARE Oregon, and for those of you that don't know, we have the responsibility with our partners across the state to provide behavioral health care for about 550,000 Oregonians. So about 1 in 8 people in the state, we have the responsibility to try to work with to solve some of the most hairy and audacious problems we've got that impact our entire community and all of our lives, and particularly those people who are affected by the needs for behavioral health and SUD services. And so we're acutely aware of the crisis. We have a lot of amazing team members who are engaged across the board and looking for solutions. I can't do anything without calling out Jill Archer, if anybody knows her. She is a godsend in trying to solve these problems, so shout out to Jill. And I think that we're also blessed with amazing partners in trying to serve the population. But as we talked about in the preface to our comments, workforce it's not an inconvenience. It is a true barrier to us doing what we know we need to do. We've built in systems and worked with our provider partners at all levels, hospitals, primary care, behavioral health, dental, barbershops, to identify people in need and crisis, but then quite often don't have anywhere to send them, right? And that's actually more hurtful than not knowing what they need, is to know that there's a need for them. And so, when I think about the behavioral health crisis, there are three, as my Chief Medical Officer, Amit Shah, would say, there's three things you need to know. Those of you who know Amit will know that's a regular thing. But the first is that as we think about solutions, we look for solutions that are geared around the workforce we need in the future, not the workforce we had 10 years ago. Right? There's a reason we aren't hiring a bunch of buggy makers anymore, right? You need the people that are going to actually engage in one-on-one, personal, community-based, trauma-informed care and not warehousing people or just sort of shoving them through a system. That's the first thing. The second is we have to make meaningful investments, and that's not just CARE Oregon. It's not just the CCOs. It's everyone, every payer, every hospital, every governmental entity has to invest in the long term, right? We have to continue to work with schools and training sessions to get more clinicians in and more credentialed people, but also work on throughput in the pipelines for folks to do peer supports, traditional health workers, community health workers, dental hygienists, just pharmacy techs. Across the board, we have to invest in ways to engage our communities, our members, our higher education and teaching facilities to say, how do we get people energized, and sometimes how do we fund, right? Not only them going through the education and training, but then on the back end, support those providers who need to give them the sort of on-the-ground training once they get out, because that's another component that's quite often overlooked. And the third thing, I think, is that we have to do a much better job of supporting people that are already doing the work. It is work that a lot of people do because they want to do the right thing. They want to serve people, they want to help people, but they're burned out, and they're scared, and they're threatened, and they're overworked, and sometimes they just give up. They've had enough, and that just makes the system work for everyone. So, one of the things on that front that we've done is we're actually working with the Oregon Wellness group to fund behavioral health counseling for nurses across the state, no matter where they work, or confidential. They can call in and get behavioral health supports, so it doesn't go on their work record and those kind of things. But those kind of sort of basic things. We've worked with our partners across the state and in health share in particular to say, how do we support providers so we can get them funding to do retention bonuses and additional training and salary increases and all those things to say, not just sort of your work-life balance, but truly your most basic needs. And so I think those are the three things I think need to be the key components to building a system that's going to really work for people. All of that tied together by the need to look at it through an equity lens. It doesn't do society very much good if everybody we hire and bring in is in Portland, right? Then our folks in Jackson County are left in the lurch, or everybody's in the urban areas and not in the rural areas, or no one speaks Spanish, or they don't understand the cultural sensitivities of our native populations. So equity's got to be infused throughout all of that, but that's sort of it's a long elevator, maybe the Empire State Building elevator speech, but that's where I start.
Felisa, you want to follow that?
Great, thank you. I think I'd just like to start kicking it off a little bit about SEIU and who we are and the work that we do. I think I often describe our union as it's a parable of the blind man with the elephant. So whatever you see us do the most is sort of who you think that we are. So, but we have 85,000 members in Oregon. We're the largest union in Oregon, and we represent a continuum of care. So over half of our members work in home and community-based care, acute care, and including the Oregon State Hospital and clinics, and then long-term care in nursing homes. And so when we think about the workforce, we really think about how people move through that system, as well as we think about the workers themselves and how they start in a system. And I think what I will say is one of the comments I really appreciate about Eric discussing is looking to the workforce of the future and not looking towards the past. What I think one of our challenges currently in workforce is we have a lot of focus on highly educated shortages. So we have a lot of focus. We still have those challenges with highly educated shortages, right? We have a shortage of psychologists, we have a shortage of psychiatrists, we have a shortage of primary care physicians in some areas. But to Eric's point, we also have a huge shortage of all of the people who support them in the work that they do. And so it's exacerbating that burnout in all levels of care. So we have an enormous shortage of certified nursing assistants. And it takes 12 years to educate a psychologist. It takes 6 months to educate a certified nursing assistant. We have huge shortages in medical assistants and the people who support them and moving people through their systems of care. And again, a year to educate, 2 years for an LPN. These are places that our union thinks a lot about how we're filling that gap. And oftentimes, I think we think about in healthcare to the equity issue, we look around and we say we don't have diversity in health. I think this is a unique situation. But we typically look around and say we don't have diversity in healthcare. And what I would argue is looking at our union, that is actually not the case. Over 30% of our members are people of color. And there are people of color in those systems. They're in every single community in this state in very large numbers. And about 15% of them, English is not their first language. What we have is an equity shortage in nursing. We have an equity shortage in physicians. We have an equity shortage in maybe some higher skilled licensures like respiratory therapy, et cetera. And so one of the things that our union has been very focused on is how do we capitalize on the workers who are currently operating in the system to see how they can become and fill those positions. So at SEIU, we operate 3 educational trusts, one in our long-term care system, where this year we've just finished graduating 600 CNAs in 3 months. We operate at a joint employer trust in our acute care system, where we have a 98% graduation rate, and 60% of the people who go through the program are people of color. Thank you. And then we also operate an additional trust with our state workforce. So all of the folks in the state that we just opened up, we have 1,000 spots in it to educate state workers to fill some additional slots in state government, which our healthcare system relies heavily on. We have 1,000 spots and 3,000 applicants. So I think that this goes to the point around how we think about how we are developing a workforce. I think for a lot of times, I feel like it's been a lot of hopes and prayers. To Eric's way, is like, well, if we just say we have a shortage and we just tell people that we have a shortage, then our higher educational institutions obviously will make dramatic changes because we told them, and then they were going to educate these people and they will come. And I really think that we've got to really adjust on how we're thinking about that. So I think right now we're thinking about the behavioral health shortage. Well, the way that we really need to adjust is we need to be much more specific, much more intentional about how we're investing in the recruitment of workers, looking internally at our own systems to see how we can make people move through the process and want to move through the process. We need to look at the barriers that we have set up. I am going to risk saying this in a room full of healthcare folks, but the protectionism of scope needs to be discussed. And that, I think, is one of the key things to looking towards the future. The protectionism of licensure needs to be discussed. If we want to have people who come into this as a calling, who believe that they can stay in this, we have to give them the opportunity to move forward, to move up, and to be providing the care that they are qualified to provide in the right setting at the right time. And we need to worry less about, I think, specifically who and how that is happening. I know it's dead silence in here. You can accost me later about this. I'm going to stand by it with my dangling childlike feet off the chair. Sticking to it. I think, and I think the next piece of that really is sort of how we have to redesign a system. And I think that there are lots of different parts in this, including how we treat our current workforce, which is how our union spends a lot of our time. 70% of our resources in our union, 70% of work go to supporting our current members and making sure that they have good jobs. And what I will say is it's very hard to recruit workers into healthcare who can't afford their own healthcare. It is incredibly difficult when we watch and recruit workers like certified nursing assistants and other folks who can't afford to live in the communities that they are supposed to serve. We ask people to be available for 12-hour shifts. And if you have children in this room or in this space, it is very difficult to get a child care provider who will watch your child for 12 hours. Not only that, who will watch your child for 12 hours on a 7 p.m. to 7 a.m. shift. And so all of these things are exacerbating the workforce crisis. And then I do want to also just recognize the effects of the pandemic. Workers who worked in healthcare in all sorts of settings, we called them out of clinics, we called them out of dental practices, we called them into hospitals, into facilities, where they watched the most number of deaths, more than any other soldier in any other war, and we said, keep going. And that is very real. We don't talk about that experience in other settings as burnout or as quitting. It was a traumatic event for each and every one of them. And we said, keep going. And so I think we have to recognize how we're building people to come to this work, but also how we have to support and engage them in their own resilience to stay in that, recognize when they need a break from that, and then welcome them back when they're ready to come.
I think that's a really great comment too, because Felisa, you're also talking about the behavioral health needs of the workforce, which is a layer to this that we don't always think about. Eric, any comments back to what Felisa was saying?
I think just ditto everything you said. It's magnificent. I think it's spot on. I think it also sort of opens the door for, state reform policy conference, right? I mean, now what do we do about it? Right? That's where the rubber hits the road. And I think we talked about some of the things that we can advocate for with our legislative, administrative, and government partners, particularly around licensure. And I mean, there are barriers that just don't make any sense. They really don't. If we accept that this is a crisis that needs to be solved, someone's got to give on something, right? You got to just suck it up and let us get to the access we need so people get the care they need to survive. And that just seems like a no-brainer. So I think that's the first place we start. And then I think, we also have to recognize that a lot of institutions need to step up and put their money where their mouth is, right? Because much like we heard, in the George Floyd times or in COVID, everybody's put out a statement. Everybody talks about equity. Prove it, right? I think we at Care Oregon go out of our way to move money into the community to support our partners and do things. We work with Jackson Care Connect down south. We work with the Columbia Pacific in the North Coast. We work with Health Share in the Metro. We work across the state, not for a vanity play, not that there's anything we necessarily get out of it, except that we belong to this community, and our members are better served if our communities are stronger. An example is I was privileged just last week to be in Seaside, where we did the official groundbreaking. I guess we put a hole in the wall with a sledgehammer, not turning dirt. But we purchased the Red Lion Inn in Seaside with the express intent to use the inside of that sort of enclosed building part as transitional housing for members, and then the outside part where the doors actually face outside as transitional housing for workforce in the area. Those hospitals and clinics, as tough as it is for them to hire people to serve the populations, people take those jobs and can't find anywhere to live even temporarily, right? So we said, let's just step up and help our partners at Providence Seaside and at Columbia Memorial Hospital and at the clinics to get people who can at least come in and get their bearings and find somewhere to live. I mean, those are the kind of things that aren't, they're not a huge glamorous project. There's no ROI, right? If I didn't have a board of directors that said, all that be damned to do the right thing, it'd be tough. But there are a lot of institutions and entities in Oregon that I think could do the same thing. And I think it's up to all of us to challenge each other to step up and make those moves, because this is something that's not going to have any one entity solve. We can't have folks dying for credit on this. Everybody's got to sort of pitch in, and the workforce deserves it. The 4 million Oregonians deserve it. We see what it does to our inner cities. We see what it does to our communities. And let's challenge each other to put our money where our mouth is.
We're going to turn to questions from the audience. I think Felisa, you used the term equity shortage, which I think is a really interesting way. It's not just a workforce shortage. It's within that, which I think is really critical. But this conversation about retention and the workforce that is here now is also really important. I was at another State of Reform conference, and there was a conversation. It was an innovation, I guess I'll call it, in rural schools where they had bought a number of RVs and were parking the RVs on school grounds for the teachers to live in when there was nowhere else to go. Good and bad, right? Why do we have to do that? But, we've got to be innovative. So I think, and recognize those needs of childcare, housing, and other things of our workforce, not just the workplace itself. Thank you for those comments. So we have a few minutes for any questions or ideas that folks have. I have somebody right in the middle here. Got a mic coming to you? Or you've got 2 mics coming to you? Yes? Thanks, Patrick.
We talk a lot, and we have talked a lot today about why people are leaving these jobs, but why do people choose these jobs, and why do people stay?
Yeah, it's such a good question. When I talk to our members about why they continue to do the work that they've done, and why they stay, 20 years, 30 years in these roles, I think that there are a couple of reasons. One is they feel like they're making a meaningful difference. I think is a huge reason why our members stay doing their work, and so they can see the work they're doing. I feel like that's I think probably the number one reason why healthcare workers stay is they care about the work that they're doing and they see it as a part of something bigger. On the flip side is that when they don't have that support and see that, then they're at risk of leaving. I think the second piece is they're able to stay because it keeps up with the cost of living and how they're able to support their family. So they're able to stay they don't necessarily need to job hop or change careers or do that because they can stay and sort of make ends meet doing something where they are making a meaningful difference. I think those two things combined give somebody a 20-year or 30-year longevity. When you don't have those two things combined, in our experience, you watch major turnover. So we can look at some specific examples in the union about workers before they were union. A clinic would have a 60% turnover. Now, after their second contract, that's down to 20%. Because those two things were combined.
Yeah, I agree. I think, not only with our partners, but at Care Oregon and not-for-profit, for most of our staff, it's about mission. It is about the idea of doing the right thing, serving people in your communities. And the challenge we have as leaders is to make sure that we don't penalize them for wanting to do the right thing. There are a lot of companies that pay a lot more money than a not-profit's going to pay. I think a lot of our provider partners see people moving sort of throughout different kinds of organizations because this kind of company pays more than that company, and the next company pays more, and so people move through the deal. So we've had to do things like we've added holidays and volunteer hours, and we absorb health cost increases every year, and we added a sabbatical program. I mean, we want people to be energized and refreshed so that they stick around, so that they have the wherewithal to do that and the mental capacity to engage, because it's not only meaningful work, it's sometimes painful work. I mean, we see the sickest of the sick. We see the folks that are in the worst states, and that's not something that people can turn off when they go home. And so we have to recognize that it's also part of our job to say, let's have them be part of the community. Let's have them be part of a family and support them, as Felisa talked about, because the last thing we can afford is for them to say, hey, we're going to go work somewhere else or some big national company or some other industry that's going to pay me more and not have to deal with that kind of grief. Then the system will be even weaker.
I think the other thing I'd just like to add is, why do people come into this work? Because I think one of the experiences I think is very interesting is they know somebody doing the work. So when I talk to our members, the vast majority of them, they either come in through experience with a family member. When it comes to home and community-based services, right? You have a family member who needs full-time support, and so you come in through that program. But oftentimes when I talk to our acute care healthcare workers and our nursing home workers, what they'll say is, oh, my cousin told me about a job that was open here, or my aunt is a nurse, or I talked to my friend who works at this other facility or this other place. And so I do think that there is a community of care that could be created on the recruitment front using our current workforce to bring people into the workforce. And I think, I don't know, how many physicians are in the room? Do you want to raise your hands? Great. Just be proud. Come on, Janine, put your hand up. Be proud. So how many of you knew a physician in your family or somebody immediately close to you before you became a physician? Yeah. So I think that this is I know that we don't, it is not the same where you're the blacksmith and so your kids have to be blacksmiths but it's still very true, right? If you were exposed and have that experience somehow, you can come into a workforce. So we should figure out how we give more people those experiences and make it an environment where you do say, oh, hey, I have this great job. I get to help people every day with severe and persistent mental illness. You should do this job too.
Other comments, questions, ideas? Oh, we got somebody in the back, and then
Thanks so
somebody-
much. The Red Line Project is so exciting to hear about. In addition to, I love the call to action, and in addition to the investment that you brought to that, could you speak to what barriers you might have encountered or any lessons learned in getting that project cited in the community with that really innovative transitional housing and workforce housing model?
Yeah, I think that's a great question. I think that we were lucky in that, as I said, this work companies can't do it on their own quite often, particularly talking about housing. And I've had a lot of conversations with a lot of people about different rules around zoning and housing and density and infrastructure. I mean, just let's make life more difficult if we can. I think that we were lucky in the Red Lion because the county government and county leaders, the mayor was there at the opening, community groups that are going to actually manage the on-the-ground work for us, classroom community behavioral health. They were all part of the process. So we got buy-in on the concept, and then, you almost dare people to push back on things like that, right? I mean, peer pressure and shame are very powerful tools. I think you use what you can to get the job done, but I think in that community, they were all in. The mayor greased the skids and got things done faster than we could imagine. The person that sold us the building was very amenable and worked with us quite a bit. And so we're excited. I think we're going to work hard. I think the real work starts in December. We're hoping it, let people in there in the spring or early summer and try to make a difference. But a lot of it's going to take, again, rules and regulations. We see that particularly in the city of Portland. I know my good friend Dan Field has a big challenge trying to help solve some housing issues in the metro. And a lot of it are barriers that we've put in place ourselves, or that that we're trying to protect something, and we just need to get over that.
I think I saw a question here.
Mike Pennington, retired radiation oncologist in Corvallis.
You got Mike. Hang on, you got a mic coming for you.
Support a plan that simplifies our healthcare system and will greatly reduce the administrative overhead and the moral injury that our providers are facing right now as they see what patients need but cannot allow their patients to get what they need because it costs too much. Oregon's been a leader in healthcare for sure. What are the obstacles that you see for us getting to a universal healthcare system?
It's kind of a topic I was hoping I wouldn't get that question. I think
Mic's not working.
Yeah. No, I think it's a good question. I mean, I think that, I'm in the non-for-profit sector. I've been doing community-based, hospital and, system-owned plans for a long time. I'm more about universal coverage, the universal payment. I think we get wrapped around the axles. We talk about who's actually cutting the check. I think there's a lot more intricacies into what that means than quite often people understand or recognize sort of the downstream impacts. I think the one thing that we can agree on is that we've got to take the red tape and the bureaucracy out of the system. We've got to really prioritize the work between a physician or a provider and the patient as primary, not artificial barriers from either the payer or the city or the county or the state or the federal government. And we've got to break through those kind of barriers and take some of that stuff out of the system so we can really do things. But I think that companies like ours enhance care for people. I think that there have been a lot of places where the old Medicare system, right? It's a great system, but there's a reason Medicare Advantage was created and brings extra benefits and brings additional quality and cost savings in the system because there is a check and balance, but you've got to hold people accountable who you're, delegating that work to. You can't just let, whether it's an insurance company or a provider or anybody else, just do what they want, but it's got to be reasonable. So I don't know if I successfully dodged your question, but that's about as far as I can get on that.
Well,
I support a single-payer system. I don't.
I'm going to go ahead and call it there.
Thanks.
You're welcome.
Great. That's
right
how we
after
go
you went.
out. Yeah.
I think that a lot of what we've been talking about today, even in that last question, is how can we get closer to the vision that you've been articulating throughout in the day in your questions, but also that we've all been talking about here, about braiding and blending funding so that for an individual, it is universal. It's not about where the money comes from, but about the services that we're able to deliver. I've heard a lot of that vision and that excitement and that partnership throughout the day. I really hope you've had an opportunity to maybe form new partnerships or refresh those for achieving the kinds of outcomes that I think we're all looking for. I want to thank the State of Reform staff for the efforts in putting this together, the State of Reform sponsors for this conference. Yes, thank you. Absolutely. They do an amazing job, and in 3 weeks we go to another state and do another meeting. So it's a really impressive, which gives me the opportunity to see all these things come forward in different states, which is an amazing opportunity. Maybe we need to do a cross-state State of Reform workforce meeting. I think that's next.
We can do that, and I'll also advocate for us to unleash the power of the CCOs. Let them do what they were designed to do. I mean, that's one of the answers.
Yeah.
I got to throw that in.
Yeah, that talking point had to come. I love it. I love it. That's right. That's right. Thank you all for joining us. Thank you to our sponsors. Please join us for a reception.